Hello and welcome to this webinar hosted by Palliative Canada. This is the fourth in a series of webinars that have been launched and delivered to address COVID-related issues, at least from a palliative care perspective. I'm Dr. José Pereira and I'm a Scientific Officer of Palliative Canada. I think it's important that we remember from the outset that palliative care is not just about the last days or last hours of life. And in this time of a pandemic, and when we listen to the media and we're hearing people discuss the importance of palliative care, because palliative care is making a big difference for many people, that I think that there's this tendency to relegate it back to the last days or hours. So we've got to remember that palliative care begins early in the illness trajectory, right across the illness trajectory. And for many patients who are suffering from symptoms of COVID, even if they are not on an end-of-life trajectory, they can benefit from palliation by way of methods to improve their shortness of breath and other symptoms. Now, this particular webinar is going to focus on medications and shortage of medications. Many of us out in the clinical world have been seeing difficulties accessing some medications and sometimes some formulations of different medications. So we thought we would host this and get the input and the insights of a group of panelists from across the country. So we've got an excellent panel today. They're folks that represent different settings of care, from home and hospital to long-term care and the ICU. They're all palliative care experts. They're from different parts of the country and also different professions, as you will soon hear when we introduce them. Now, the format today is going to be more of a panel discussion rather than a presentation, a formal presentation. We're going to be posing some questions to the panelists and then drawing upon their insights and their experience. Now, this is also a fantastic opportunity for us to do some crowdsourcing, as it were. So we've got several hundred participants actually online. There is an icon, a feature at the bottom of your screens that says Q&A. So please feel free to submit comments, questions using the Q&A. And by doing this, this large community of several hundred people could build more knowledge together. And we'll collate those ideas. And one of the products of the webinars is, after the webinar is put together a document that captures the tacit knowledge that exists across the country. Now, we recognize that there's a lot of variability across the country and sometimes even within regions. So within even one region, there can be shortages in one setting, but not another setting. In a province, there can be shortages in one region and not in the other. So we recognize that. And so you will hear a lot of the variability from across the country. But I think we'll hear some common themes emerging as well. Just some quick housekeeping. Your microphones are muted, and I'm sure you understand that because it's so difficult to do it live with hundreds of people. So we do ask you to please share your questions and comments through the Q&A icon. The session is being recorded, and within a day or two, you'll be receiving an email with the link to the webinar. So it'll be made available to colleagues and other folks who weren't able to be with us today. I've introduced myself. In addition to being Scientific Officer of Palliative Canada, I'm also Professor and Director of the Division of Palliative Care in the Department of Family Medicine at McMaster University in Hamilton. And I want to introduce now our panelists. I'm going to actually ask them to introduce themselves, starting with Dr. Amit Arya.
Yeah, so I'm Amit. I'm a palliative care physician working at William Moser Health System, Brampton Civic Hospital. Our sort of program is pretty comprehensive, where we do community home visits, we go into long-term care facilities, we work in a hospital, and we have an acute palliative care unit and a consult service as well. And as you can see, I have faculty appointments at McMaster and U of T.
I'm Ed Osborne. I'm a family doc in Beaumont, which is about an hour east of Toronto. I work at hospital and community, so mainly Lakeridge system. I also teach through University of Toronto and Queen's University, as well as appointment at Ontario Tech here close by in Oshawa, and public care lead in the area, Central East lead as well as the Regional Cancer Center.
Hi, I'm Susan MacDonald. I'm In St. John's, Newfoundland, I only have one university appointment, so at Memorial. We have a small consultative service that provides tertiary level palliative care, but we also see patients in the community and in clinic.
I'm Patty Rice. I am a community pharmacist, also in Bowmanville, Ontario, and I sit on the local community palliative health team.
Hi, James Downar, the division head for palliative care here at the University of Ottawa, and I also do critical care here in Ottawa.
Fantastic. Well, thanks for joining us. Just quickly in terms of declaration of conflicts, Pallium Canada is a non-profit organization. It's pan-Canadian right across the country. Our mandate is to improve access to all Canadians, access to palliative care, and we do that by educating healthcare professionals on the palliative care approach and also helping health systems build up that palliative care approach. And some of our funds are generated through sales of our Pallium pocketbook and also through registration fees of our LEAP courses. I'm paid by Pallium Canada Scientific Officer.
Yeah, I also receive honorarium from Pallium as well.
And I've received honorary and speaking fees from Boehringer Ingelheim, but nothing related to any medication recommendations that I'm going to make today.
Very good, thank you. So the learning objectives for this webinar is that we're hoping that by the end of this webinar, you'll be able to list medications that are commonly used in palliative care, but that may be facing short supplies during this pandemic. We're hoping to generate a list of options. If those medications are not available, then what are the options to manage various symptoms? And then also, very importantly, is how can we be stewards as well and be proactive in this by looking at strategies to reduce risk of medication supply problems from a healthcare professional's perspective. But perhaps we can also capture some ideas about how other entities like provincial governments or provincial entities could help us also address this potential shortages. The webinar is divided up into three parts. The first one is I'll provide a bit of a context, a few slides on a list of symptoms and the usual treatments that we use in addressing those symptoms in palliative care. The main part of the presentation of the webinar will then be part 2 and part 3. Part 2 will be, I'll be posing questions to our panel, and part 3 is we'll be looking at your questions and answers and your comments in more detail. So let's get going right away. This is a satellite view of a one-page protocol that we put together at McMaster University on the management of dyspnea. It was a protocol that we used the Fraser Health protocol in the BC Centre for Palliative Care protocol to build ours. So I think a lot of similarities across them and across other guidelines that we saw. The main point here is that for the management of dyspnea, opioids, particularly if it's severe dyspnea, is the role of opioids and the safety of opioids in that role. And the protocol also calls out for those cases that are more difficult, the use of midazolam or methotrimeprazine. Airway secretions, if you go across the country in different protocols across the country, the most common approach is the use of, for those cases that are severe, the use of scopolamine or glycopyrrolate, and that's by subcutaneous injections on a Q4-hour PRN basis. But we also recognize that in this pandemic, we're seeing our colleagues who are right in the front lines of the care are seeing a lot of adult respiratory distress syndrome and pulmonary edema, and there's a role for furosemide IV, although in the palliative care literature, it's also been written up as subcutaneously. In the area of cough, another frequent symptom in COVID-19 disease, we've highlighted that in the severe cases of coughing is the use of opioids, and their morphine and hydromorphone is usually listed as the usual medications across protocols across the country. For cases that have got moderate coughing, medications like dextromethorphan, hydrocodone, codone, and normethadone are usually listed in protocols across the country. Now, I'm now going through this fairly rapidly, but I really want to get to the panelists as soon as possible. For delirium and agitation, the first line treatments are usually haloperidol or methotrimeprazine. Often PRN, but if it's severe, then on a regular basis, on a regular dosing regimen. And for the very difficult cases where there's severe agitation, midazolam. So again, these are the usual ones prescribed across the country or recommended across the country. In the area of nausea and vomiting, the usual options are metoclopramide, orally or subcutaneously, and then ondansetron, orally, subcutaneously, or IV in some cases, and haloperidol, again, which can, in small doses, can be a useful antiemetic. Again, in the management of pain, I want to highlight opioids. And again, the usual opioids across the country, particularly if a parenteral route is required, are morphine or hydromorphone. There are other options, and maybe we'll speak about those today if there are any issues around morphine or hydromorphone availability. And for anxiety, the guidelines usually recommend lorazepam or clonazepam. So, moving on to palliative sedation, which is probably one of the more difficult ones. At McMaster, we convened a working group to look at what protocols can be put in place within the context of the pandemic. And we recognized very early that there may be shortages with the commonly used medications, which, as I mentioned earlier, are methotrimeprazine or midazolam. So we came up with a few options. And one option was lorazepam, subcutaneously or IV, although it was mentioned that the subcut might actually be difficult because it's quite a viscous fluid. So maybe we'll hear from our pharmacist about that, or from James, who works in the ICU, maybe uses that more. The other option was midazolam by intermittent injections, because there can also be shortages of pumps. So the idea came up of, we might have to also provide the potential option of intermittent injection of midazolam, although that's not ideal because of the very short half-life of midazolam. But other options are phenobarbital. Usually in the palliative care literature, if you see it, it's usually recommended as a second line if midazolam or methotrimeprazine are not effective. But I guess in the context of a pandemic, if there's shortages, we may have to think of that as a first line. And then we had to reach far to look at other options, and one of them was chlorpromazine. Now, in Canada, we are told that there's no parenteral formulation available, but it is available rectally. But I'm just throwing it out here as possible options. So with that, I think let's go to the crux of the presentation, and that's the question. So I want to start with the first question. And the first question is, what shortages are you seeing or hearing about in your various jurisdictions and settings? And maybe if we can turn to Amit and Ed, if you can share with us your thoughts.
Yeah, maybe I'll just get started there. Thank you, José. Yeah, I think one of the shortages that both Ed and I have heard about, and I've actually heard from several colleagues across the country as well. The number one medication that everyone's talking about is methotrimeprazine. I have heard about midazolam running short as well, and I'll let maybe Ed speak to that. But at our specific site, that's not an issue for now. Glycopyrrolate, which is also on this slide, an anticholinergic medication, has also been an issue, but we've checked about scopolamine, and that specifically, hasn't been an issue right now. Hasn't been an issue.
Right. The midazolam shortage for me was primarily looking at surge and something happening in the future to have a plan rather than get caught short. Trying to save it for ICU use, but also in the community, remembering the community has already been short. Even a few weeks before this started, methotrimethoprim, I was told, was already short. when I ordered some for a community patient. So looking at different locations is critical as well, depending on where you're working. When we were talking about the surge as well, we were looking at using more phenobarb. I more or less used to use it as third line in the past, but maybe going to first line, and did get a few calls to say, if you start using more of that, we based our need on historic needs. And so if you start using more, you may run out again. So it's looking at future needs as well as present needs.
Yeah, on our order set where I work, we've actually added phenobarb as like we have a COVID-19 specific order set where we've actually added phenobarb, you know, for sure, with sort of the RAS score, of course, to monitor palliative sedation. And, you know, part of the idea around that is that, well, if you don't have the delivery the delivery systems like the pumps and so on, you know, having a nurse don PPE, for example, and going in and again to give a short-acting medication like midazolam isn't that ideal. So phenobarb was sort of you know, better alternative in that circumstance too.
Right. The last comment is about haloperidol. I might sort of extend the use PO or liquid before I go to sub-Q just to maintain supplies. And the other thing, if you take anything away from this, is get in touch with your local pharmacist. Patty and I work together, and I reach out to her and the team regularly, say, okay, what do I have available? What can I use? What are my options? They come up with some good options, not just different drugs, but different routes. And remembering pharmacists compounding can help as well. So all these things, if you take one thing away, just contact your pharmacist and be in touch with them regularly.
Yep, absolutely. And I think like our pharmacists are very valuable resources on a regular day, but we've been in touch with our pharmacists in multiple different locations to add to that. And as I'm sure, you know, a lot of people are. So like we've called sort of the pharmacists that supply the long-term care facilities as well. You know, we have one pharmacy, Kalia, which kind of supplies injectable medications and makes symptom management kits. And those have actually been restructured, where methotrimeprazine firstly has been removed, you know, out of those kits just because there's such a short supply, and also our hospital pharmacist as well.
So Amit, can I ask you to keep that, because when we come back to the third question, which is what strategies can we use to mitigate shortages, if you could just highlight that again, some of those approaches that we could be looking at. Patty, I wonder if you could take this question next.
So I think the big thing I want people to recall is that what's available today and what's available tomorrow can be totally different. And what I might tell you I can get today, it might come in and say it's going to come in, and then the next thing we know it doesn't, or vice versa. It says it's not coming in, then it does. So it's a very constantly changing question, and so don't be afraid to ask, but sometimes we can predict and we're not getting good clear answers either. So it depends on the day, unfortunately.
Maybe we'll stick to Ontario and then move over to our folks out in Newfoundland. James, your thoughts on the question of shortages?
Yeah, we had some concerns early on. There was quite a surge of symptom management kit ordering towards the end of March, which put us into the sort of, you know, slight warning zone about stockpiles, but that's been replenished quite quickly. Ottawa is very fortunate that we kind of have one big community supplier for injectables, and we have one big honking hospital. So what's happening is that a lot of medication suppliers now on their own have, in order to try to head off the hoarding issue, they're starting to dispense and allocate ration what they're giving to hospitals, organizations, etc. And what they're doing is they're doing this based on historical usage, as Ed was suggesting. So like what your average month's supply is. Now that's great if you happen to come from a large organization that would be ordering a bunch of this stuff anyway, right? So big hospital with lots of elective surgery is going to have buckets of certain medications like midazolam for outpatient procedures that are now not happening. So we're going to have a good supply. But if you come from an area that historically doesn't use these medications and you're going to try to ramp them up, I think that's going to be a problem. But I was very happy to report that literally the only medication right now in the Ottawa area that anyone's talking about being short of at the moment is the paralytics, cisatracurium, which I'm hoping nobody is using at home.
Okay, very good. Actually, I think what we'll do is we'll field some of the questions now and the comments right now. And I see that folks who are posting on the Q&A board of putting in brackets the province they're from. So that's a fantastic idea. So if you're coming up with a question or a comment or an idea, please add the province you're from. I see Pam out in New Brunswick identified that they are short of injectable Haldol. Now that's interesting. I wonder if there are similar shortages elsewhere. And there's also a question about Nozonan, so methotrimeprazine, both the PO and parenteral. Question is, I presume, are there shortages in both the PO and the parenteral?
In Newfoundland, we've had problems getting injectable Haldol, but we're used to, because we live on an island and supply is hit or miss depending on the weather and the ferries and everything else. We're kind of used to doing that. So, and according to the pharmacist I spoke to the other day, it's back in stock. So who knows?
So Susan, actually, there's a good segue to go to Newfoundland. I'm going to hop to New Brunswick and then over more east. Any other issues you've been encountering in your province with respect to access?
No, not yet, because we have very small numbers. If you've been looking at the numbers of cases that we've been experiencing, we're actually we're well behind what's happening in Ontario and BC. So we really haven't had significant issues as of yet.
Okay, very good. So I think let's move on then to the next question. So the next question is, what other options could be considered if medications run short for each of the following symptoms or treatments? So I'm going to now take the panelists through a series of slides that lists the symptom or the problem, the usual medications, and then the discussion is going to be around what options are there if these medications are not available. So we're going to start off with delirium or agitation, and you may remember that at the beginning of the webinar I said that the usual first-line treatments in the protocols and guidelines are haloperidol, methotrimeprazine, or midazolam. So maybe at this point, Susan, could you maybe kick off this one? Other suggestions that you might have?
Well, I think the first thing is, before you even start with medications, is look at, as we always do with every symptom, is, are there other things that I can be doing for this particular symptom that don't even require medication? So are there medicines that I can get rid of? Is there other causes that I can get rid of before we even start with medicines? Maybe that's probably part of the strategies. I don't know. But that would be the first thing that I would say before we even start with that. You know, we tend to use things like the Haldol. Olanzapine is pretty common here, depending on the physician. I don't really have any big suggestions other than what you've got written. Maybe one of the others will be able to answer that better.
Okay. Amit?
Yeah, so that's a tough one, right? Because of course, when we talk about delirium, we always talk about Haldol and methotrimeprazine. So I think you know, olanzapine would definitely be another medication that could be used. I've used it sort of in the past because, you know, there's a sublingual wafer sort of, you know, formulation that you can put underneath the tongue. So you have another route, right, which is not really the oral route. And I think that would be the sort of alternative medication that I would go to. I mean, one thing that I'm hearing about on this note that I think about is that people are kind of being creative. And I wanted to even bring this up, that I'm hearing that people are kind of layering these medications a little bit more too. So, you know, maybe if they don't want to just sort of use up a whole bunch of Haldol, even in a single patient, I'm hearing that people are sort of saying, okay, we're going to use some Haldol and olanzapine, which is a little bit more sedating.
Patty?
So the other one that I found reference to was in the BC guidelines. They list loxapine. So not a new drug by any means, but in Ontario, it's still showing as available, both as an oral tablet and as an injectable. So whether that might be something, if really nothing else that you had more common use or experience with is available, perhaps that could be something worth considering. The other thing is to think about other routes. The dissolvable or ODT tablet was mentioned. Risperidone is also available like that. Rectal can be compounded, sometimes even topical. Transdermal is an effective way if you need something other than oral.
Do folks have a sense of how effective are these different strategies? I remember lorazepam using that many years ago, about 20 years ago. And I cannot reach into the depths of my memory, which is probably not there, about what was the advantage of pros or cons of that medication.
You mean loxapine?
Yeah, yeah.
So I think more of an antipsychotic. So I've not seen it often at all in my practice, but it was listed as a possible something you could consider, I guess, if nothing else was, I'd have to do a bigger search on it.
I can tell you a little bit. I mean, it's been used, as many things. It went off to hide in the ICU world for a little bit, I think, where it's one of the small number of atypical antipsychotics that you can give parenterally. And for whatever reason, it found a nice little petri dish in France where they use it extensively in their ICUs, and they've written a fair about it, where they'll use it in quite high doses as effectively almost their only sedative agent. ICU's really moved away from using atypical antipsychotics for sedation based on some recent study results, etc. I would say that my own experience with it is very similar to my experience with methotrimeprazine, which is that it sometimes works pretty well, but then other times you can go to quite high doses and you don't see any result at all. But I would say I would put it in the same bucket as Nozamin.
Okay, and your thoughts? So with olanzapine, you had mentioned, I think, Patty, that the dissolvables can be used if you can't get access to the parenteral, because the olanzapine is, I think, is written up for intramuscular, but in palliative care, it has been reported being used subcutaneously. So the intramuscular formulation being used subcutaneously. Any experiences with that? Does anyone have any experiences with that? No.
Even in the ICU, we tend to use the Zydis, the oral dissolving tablet, and because it's just cheaper and there's no particular reason to give it parenterally unless you really can't, if they don't have a mouth for whatever reason, but I can't see why you wouldn't be able to give it by Zydis. My suggestion would be, I think it's generally cheaper and more generally available to use the Zydis than the injectable.
Very good.
The Zydis dissolves very quickly, so there's no real advantage to the otherwise. That would be my experience. One other comment is using risperidone, even liquid early on, saving the Haldol for the sub-Q has been helpful for me.
Okay, very good.
Yeah, I think this will come up a little later, but another thing I wanted to add is that for some of the patients that we're hearing about, in fact, many of the patients that we're hearing about across the country and in my own practice that I've seen with COVID-19 specifically, they decline so quickly. So I think sometimes I personally have had a low discretion for moving to sort of the second part of the slide, which is palliative sedation and more of the benzo type route rather than the antipsychotics.
So actually, that's a good segue to the next one then. So do you want to elaborate further on that, Amit, around the palliative sedation?
Yeah. So from what I've seen in my own limited experience, where I've cared for some patients now who have COVID-19 and are at end of life, and just also speaking to many colleagues, across the country, the trajectory of these patients is, very rapid and quite acute in that they usually present in sort of acute respiratory failure, ARDS, and have severe symptoms. So I guess what we're talking about on these slides has to be started, very quickly whenever they sort of present in whatever setting they're at. But I mean, just to even tie that in our order set, we even have that if, say, somebody has had 3 doses of an antipsychotic like Haldol or methotrimeprazine, if available, well, then if that's not working and, the patient is not comfortable and their RASS score is not at a particular point, well, then we should move to sort of, palliative sedation. As I mentioned on our order set, and this kind of ties into what we're talking about, we have phenobarb as a preferred agent, just for the intention that, midazolam midazolam is sort of, you know, shorter in its duration of action. So you would need to give multiple doses, and that sort of, in the hospital setting at least, would be using up personal protective equipment.
Okay.
I think it raises the point about having a palliative sedation discussion early, so it's before they actually have a quick decline. You introduce the concept of palliative sedation very early on, get people prepared for it, so that's not a surprise when it comes up.
Yep. Yep. Just to even hammer that point in a little more, I mean, we're seeing that it's not sort of usually on our PCUs or these type of settings like hospice, we may have maybe some proportion of patients that need it, but it's not very high. But for these patients, I think many of us would hopefully agree that there's definitely a much higher proportion of patients that would need palliative sedation.
So I'm hearing the approach of maybe not necessarily, not lowering the threshold as it were, but getting prepared for it much earlier. But how do you balance that with concerns that some folks have that palliative sedation may be used inappropriately or too rapidly? How does one find that balance, that sweet spot? Any thoughts, Amit?
Well, I think it goes to best clinical judgment as always, right? And this is something we've always done in palliative care. I mean, we know that when we're giving medications like like methotrimeprazine if available, or Haldol, or olanzapine, we can kind of observe their effect on the patient, you know, a while later, and sort of just come back and reassess and see if the medication is having the desired effect. And if we have a patient whose prognosis is hours to days, we know that, you know, based on guidelines that have been put out by the CSPCP, the Canadian Society of Palliative Care Physicians, or in Alberta or BC or whatever jurisdiction we work in Ontario, we usually work around those guidelines. You know, that patient would definitely be, you know, would definitely benefit from palliative sedation. And I wanted to emphasize also what Susan said, is that it's still very important to, you know, look at the whole patient and not just sort of give just keep on giving medications, right? So especially in a hospital setting, I can tell you that, you know, part of that is educating our colleagues in the emergency departments and sort of really who are at the front line of sort of seeing these patients where, you know, they don't follow their usual practices, which may be quite a bit different, right, in terms of how they manage delirium and other symptoms.
I think the key point Amit said was also reassess. So ideally, I'd like to use medication that perhaps aren't sedating, but these are part of the side effects. If you reassess and see the goals, and actually, sometimes you actually will lean back a little bit, but the comfort of the person is the paramount, especially with these patients when they feel dyspneic. So I think reassuring people that we'll be reassessing, it's not just one-time deal in sedation. It's one of those things that we need to keep assessing the patient.
And that's something I think that's a really good point, Ed. And I think it's something that for those of us who may be working in a more distant relationship and we're providing a lot of advice for people who are on the front line, if we're not physically there ourselves, is reminding people that these patients need to be reassessed and reassessed and reassessed, and that you start off your medication as low as you can go with the smallest amount you can get away with to relieve the suffering the patient has, but that you're constantly rechecking, because you may have to adjust. Very
good. What is the thinking around lorazepam? Because you know, some people have suggested that as an option if there's a shortage of methotrimeprazine and midazolam, but others I've noted there's also concerns about potential shortages of lorazepam. Patty, do you have any experience with that or thoughts around that?
Orally, lorazepam is available. Locally here, lorazepam injectable doesn't look to be available, not at this point anyway. So from that perspective, you know, you've got sublingual, you could compound it into an oral liquid to give other ways, but for sure injectable could be a problem. At least it looks like it here right now.
And chlorpromazine. So am I correct in saying that it's not available in a parenteral form?
Correct.
In Canada?
As an oral, or powder is available, so you could make it into a rectal. And
what's the absorption like rectally?
I don't have numbers. It's definitely something that's been used and not foreign. For sure there would be numbers available.
Okay, very good. James, I haven't forgotten you, because I think I really, at this point in time, I think your insights, especially from ICU, are going to be very important on this one. So we've actually put together some slides that will help, there we go, in exploring what is it that our colleagues in the ICU are using. Now, this does not necessarily mean that we need to bring it out of the ICU and use it in different settings at home, etc. But I think some of the insights from there might be very helpful. So James, I'll hand over to you here.
Maybe I'll throw a word in about lorazepam, which I did used to use a lot. I remember even as an intern, one of our favorite things for an agitated patient back in the day was the 5 and 2. People remember the 5 and 2. You put 5 milligrams of Haldol and 2 milligrams of lorazepam in a syringe and shoot that intramuscularly. The thing about injectable lorazepam is that it's very thick. And so it's sometimes hard to draw up and stuff like that in small doses. And sometimes people actually dilute it in saline because it was designed, when it comes supplied, I believe, with the goal of intramuscular or subcu injection in mind at very, very low volumes. So that's one tiny little problem you might encounter. But in terms of dosing and pharmacokinetics, I would say that it's not that different than midazolam, like a very similar dose, very similar dosing frequency. You don't tend to get the amnestic effects that you see with midazolam as much. It tends to be a bit more disinhibiting, I would say, or like, I guess, similar to midazolam. And I would say, it's one of the early suggestions for people in status epilepticus to use that, and you just kind of bang in 2 milligrams at a time to try to get them under control for status. I don't think it's wrong to use a similar approach for sedation. So turning to some of the fun ICU medications, I want to be very clear. I'm going to sort of finish off with a caveat about some of these medications because I'm not so sure how helpful these will all be in most contexts in palliative settings. But using propofol or Diprivan, if those of you know it, so that's the sort of white stuff, it's a bit of an issue that you have to have. You can't give it sub-Q. Obviously, you can't give it PO. It has to be given IV. I did see one report of it being used through an IO in a palliative setting. Yikes, I hope we're not at that point yet. But starting with a small sort of 10 to 20 milligram boluses, so you're giving kind of 1 cc at a time. And I would repeat that up to every 30 seconds or 1 minute until you get them comfortable. I would not try to give more than 10 or 20 milligrams at a time. It's very potent stuff, right? The therapeutic window is very narrow. It also is so fast onset that if you don't see any effects within, once the IV flushes through, you can feel comfortable just keep giving and stacking the doses. So please don't overshoot, all right? Because we all know about the Michael Jackson thing. In terms of a maintenance infusion, the doses here were sort of listed. And again, I provided a reference from Downar, the definitive 18-page review of the use of propofol in a palliative sedating for those of you who are bored. I would say probably I would go very much at the low end of this maintenance infusion, sort of 0.6, not the higher end, because again, it is very good at suppressing respiratory drive. And I feel like we have to put a note about societal perception. Like we're just talking about, are people pushing the palliative sedation button too early? Let's not forget that propofol is the sort of core ingredient in a MAID kit. So whipping out a syringe of propofol for somebody who's acutely short of breath and nearing death, if you're standing there holding a syringe of propofol and the person dies, you could understand how easily that could be misinterpreted. And I would say be very, very careful about that. If you're not familiar with propofol, I would strongly urge you that unless literally there's nothing else in your golf bag, don't use it. Dexmedetomidine is...
James, sorry, can I just ask you something with propofol then? So quite a few years ago when I was working in Calgary, we were looking at putting in place a propofol protocol, but specifically only for the palliative care unit. We didn't want it to go out into the community. It had to be in a controlled environment. And even at that time, there was so much concerns with it that they said if we had a patient where those very, very, very rare cases that we're not responding to midazolam or methotrimeprazine and phenobarb, if we had to use propofol, then we had to look at moving the patient into sort of an OR or ICU or critical care setting to do the propofol. I'm hearing you sort of trying to emphasize that as well.
I mean, I would say like if we're at the point of somebody who's like comfort measures only and they've got refractory symptoms, and that's all you've got, I mean, I'd use it for sure. I'd use it. I mean, again, if you're trying your best and just using 10 to 20 milligram aliquots, it's probably pretty, like, I wouldn't think it to be unsafe. It's just that it kicks in quickly and it wears off also fairly quickly. So you can expect to have to stand there a long time, right? Like you're going to be titrating meds as opposed to something like midazolam or even, you know, diazepam, where you'll give the drug and it'll last for hours and hours and hours. This is going to wear off quickly. So it has a very short distribution half-life where it soaks into the fat and goes away, but even the elimination half-life is also quite short. So so I would say, yeah, like, but my honest advice is if you're not familiar with it, it's not really like any medication that any of us would use in palliative care. I would probably be careful about using it if you're not familiar with it.
Yeah, thank you. Sorry for interrupting you.
There's one comment I'll make, if you don't mind. There is a comfort level with some of the smaller emerge docs and emerge centers which use propofol. So again, your colleague may have experience, and I continue to do emerge. So there's a certain comfort level there, and there's certain pockets that we'd say, listen, it's not the usually used, but this is how we could use it, and you may sort of touch base with some of the emerge docs that are comfortable with it.
I think that's an excellent point. Yeah, if there's somebody around you, like an emerge doc, a GP anesthesiologist, or an anesthesiologist handy who can do it, then yeah, it's excellent. It works very well, but that's partly part of the problem. So the other one is dexmedetomidine, which I think is long been sort of something I've been drooling over to use in the palliative setting, and we're trying to get a protocol going actually to do an observational study for it. It is a fantastic medication for anyone who has any experience with it in the ICU. When it works, it's like nothing you've ever seen. So it's an alpha-2 agonist. It works on very, very good penetration of the blood-brain barrier and highly potent, and works extremely well to reduce agitation. A lot of agitation and agitated delirium is actually driven by catechols. And so blocking this may be very effective. People have actually done entire operations on people awake while on dexmedetomidine, just to give you some idea. And you'll find this stuff when it gets used quite effectively. We'll keep people on infusions while we extubate them, and then only after we extubate them, we actually turn it off. So it's an incredibly good medication for treating agitation without necessarily sedating people. So again, it's quite remarkable. If you've never seen it, it's impressive. Now, there's some issues. It can actually be given subcutaneously, although in the ICUs, it's only ever given IV. Now, one thing you have to be careful of is you can't just grab a bag of the IV stuff from your ICU and use it sub-Q. It'll be too dilute and the volume will be too high. So you have to prepare it in a higher concentration, but it has been shown to be stable in that concentration. I would suggest, here's the dosing range. I'd probably start somewhere around 0.3 or 0.4 if somebody's getting a bit agitated, and it's got a fairly short half-life, so you can go up and down by 0.1. It's very safe. It does cause bradycardia, and in IV boluses, there have been reports of like third-degree heart block. Those have never shown up on the sub-Q administration papers, so I'd say it's a pretty safe drug to use. The difference between propofol and dex in this case also is that propofol comes in a standard concentration in a standard size 100 ml bottle. So for an off-the-shelf human of 70 kilos who is getting 1 milligram per kilogram per hour, that bottle is going to last a very convenient 13 hours. It's not going to be very easy to constantly have to go into a place if you're in any kind of setting where you're resource limited and the nurses aren't there constantly. You may run out in the middle at a bad time. Dex, you can make in such a concentration that a bag would last multiple days. And so it could be a very good medication to give through a CAD pump, for example, subcutaneously. And so anyway, if anyone's interested, if I've done a good enough job of selling Precedex and you want to join an observational study, just let me know afterwards. The other one I'm going to put in a plug for is another one of my sort of favorite drugs is propranolol, which is a very old school beta blocker, the very first one they ever had. Nobody uses it anymore because it crosses the blood-brain barrier very effectively and causes a lot of central effects, depression and stuff. So the mood disorders that it creates made it so that nobody ever wanted to use it for cardiac issues. But in fact, it's fantastic for what we need it for, which is to calm people down when they're being dialed up by their catechols. So I've been using it a lot, and I put a reference here at the bottom from Schatzka, which you can look up. It's a case series of 64 patients where we used propranolol in the ICU, and we found that we were able to dramatically reduce the use of propofol, midazolam, fentanyl, lots of medications just through putting people on a bit of beta blocker. So that was very helpful. If you have to use it, I've never tried it in the, I've tried it, I shouldn't say never, I've done it maybe once or twice in the palliative setting for very agitated people. If you can still take the oral route, it comes IV, but it's hard. You have to give it fairly frequently IV. So better if you can get them on some oral stuff, and if they're able to take it, there's the dosing recommendations there. I would say in general, just to be really clear, I've been reading notes about people saying that, we've been told to save the midazolam for the ICU. Now, I understand that some ICUs are running short on other medications, but just to remember, midazolam is actually not a first or second line or actually recommended for sedation in the ICU. Since 2013, our guidelines have suggested to not use benzodiazepines for sedation. And what I've been trying to work with the ICU groups to sort of say, guys, actually the ICUs are the ones that should be using the propofol and the Precedex, and they should be saving the midazolam for the palliative setting. So everyone uses the medications they're used to using. The beauty of Precedex now is that since October of last year, it's actually off patent. So the cost has come down by 75%. It used to be very expensive. Now in the ICU, you can give it for like between 40 and $100 a day, which is, only a little more than heparin, for example, sub-Q heparin. So it's much more realistically affordable. So I would suggest as a rule, if you're working locally with people to manage supply stock, rather than trying to sort of figure out how to use propofol and Precedex, I would suggest engaging more with the ICUs, get them to use more things like clonazepam and enteral benzos, avoiding the midazolam utilization, working the propofol and the Precedex, and saving the midaz for you guys. The one caveat, of course, is tubing. Propofol, you have to change the tubing more frequently, so people are running out of tubing. That's why there might be a preference to use midazolam in this context because of tubing issues. And I'm going to stop there.
Very good. We're keeping track of the comments and questions coming in. And I think we'll cover some of them in the next symptoms as we go through the other symptoms. So just very quickly, and I'll open up to anyone in the panel to respond. Airway secretion, scopolamine and glycopyrrolate. I think there was one person that indicated that there might be a shortage of glycopyrrolate. But it doesn't sound like there's a very big issue around that. Patty, have you seen any issues in terms of access to scopolamine or glycopyrrolate?
We don't use it in the community setting, so I haven't had any reason to look for it. Community-wise, we just have the scopolamine in the patch, and that is still available, but
okay,
maybe less effective in the secretions category.
And then as an option would be the atropine drops.
And they are available again.
Yeah. Okay, pulmonary edema, any concerns around that? That's usually furosemide, so any shortages? I didn't see any shortages being reported across the country around that one.
None that I know of, and perhaps using sub-Q, which people aren't familiar with, a little bit more often than we have in the past.
Now, actually, Ed, with a sub-Q, there's a bit of a limit, right? And the limit relates to the volume. Could you say something around that?
Correct. So exactly what you said, the issue when you use IV route, it's not limited by volume, and you can get pretty high doses. With furosemide, you're looking at probably 20 milligrams, and it's not as comfortable going in sub-Q.
Okay. Cough. Comments on management of cough.
It's interesting because Patty and I were looking at cough and looking at methadone as one of the more potent antitussives, and also using methadone as a rectal suppository. It can be absorbed buccally as well, so it's very well absorbed that way in small volumes. The problem with it is it's a very tricky drug. It's long life, and I might introduce early if I'm thinking about using it long term, but it's actually a good choice if you have experience with it. I'm not sure the difference with normethadone and methadone. I tend to use straight methadone.
The normethadone isn't available right now anyway, so it was a metabolite of methadone, but not available at this time.
Okay. Susan, any thoughts on the cough?
No, nothing different than has been said.
Okay, and Amit?
Yeah, the only thing I would add is that I think from a practical perspective, I think, we might just go to sort of opioids again, right? Which would control probably the number one symptom of breathlessness, accompanied by cough, right? If possible. That's probably the only thing I would add.
Yeah, there's a question that came in from one of the registrants. It might not be specific around, it's not specific around the cough actually, but it's more generally about medications, and that is around the stability of medication. So for example, midazolam. So there's a notion out there, midazolam, and it's based on I think a relatively small study that was done in Alberta many years ago, that midazolam can be fairly stable in a pre-filled syringe for up to 30 days. But any comments on any of these medications in terms of stability or instability?
In the pre-drawn phase, is that what you're asking, José?
Yeah, I guess it relates to the pre-drawn.
So for years we had been using it pre-drawn, and the thought was it was stable, and even in acute settings in the community, pre-drawing midazolam, having it available in a dark, keeping it in a dark area because of the stability in light versus dark. There was a change from Health Canada that was concerns around that, and there's still some question, in my opinion, around that. But at this point, they still will pre-draw, my understanding, up to 24 hours. That would be a daily visit to pre-draw syringes.
Okay. Then moving on to pain. Interestingly, as I've been observing the comments coming in, there are some places reporting shortages of some of the opioids. There's someone in a part of BC that says hydromorphone. There's some concerns about it. From Northern Ontario, concerns about a fentanyl shortage. And I'm just wondering whether in some provinces, like in Ontario, for whatever reason, the opioid of first choice as a first line is hydromorphone, whereas in many other parts of the world, actually most parts of the world, it's morphine. So can anyone comment on that, particularly as I see that there might be some shortage with hydromorphone? Actually, maybe Paddy, with you, have you spotted or heard any concerns about opioid shortages?
I haven't at this point and haven't run into it. So that's not something we're having to ask for changes, but definitely just from our community experience, we see hydromorphone used more in our area than morphine. It seems to be the first choice. I think physicians find it maybe a bit cleaner is the term they tend to use, easy to dose. But I haven't seen an issue with supply at this point.
Susan, do you want to weigh in on this one?
I think there's a lot of people using hydromorphone first line. Certainly in hospital, we see a lot of patients with renal failure. So it's a little bit better than, than morphine for renal failure. So that may be where some of this is coming from. I do think, when you've been around in this business long enough in medicine, you see things coming and going in and out of fashion. And so sometimes it's just one of those things.
I do think it's an opportunity now to bring back morphine as a first line. Because I think in palliative care, if we're starting with hydromorphone, we actually start reducing the options further down the line if the doses are needing to be increased. And then if you need to switch the opioid, it sometimes becomes difficult to come back to morphine. But I just think this might be an opportunity to have a resurgence of the morphine. Amit, any comments?
Yeah, so I mean, just to kind of reiterate exactly what you're saying, José, based on kind of a similar discussion as to what we're having in the panel now, at our hospital, we actually decided only to use morphine. For that purpose, just to also keep it simple, because once again, like the palliative care is not going to be, or the end of life care for these COVID-19 patients will not just be provided by us as the palliative care specialists, but also, by many other sort of frontline healthcare colleagues. So we decided to keep it simple, just only stick with morphine, and sort of hopefully that will, have hydromorphone as a backup, exactly for the reason you suggested.
Okay. I'm looking at time, so I really want to move us to the next part. But before that, for nausea and vomiting, there was an interesting question that came in. I just wanted to pass it by the panelists, and that was, what about mirtazapine? Is that an option for nausea and vomiting?
I would say I don't know that I would necessarily start there. Like I would say, we've given a huge list of sedative medications, atypical antipsychotics. I would literally run the list. I would run the list of every atypical antipsychotic for nausea before I would go to Myrtaz. Because remember, like Nozanan was originally a nausea medication. That's where the name Nozanan comes from, right? Olanzapine is potentially good for nausea as well. There are, I think, you know, you can try prochlorperazine if you can still find it. Like I would say that those would be my personal go-tos before I would switch to a different class.
Okay, thank you. So let's go on to the third question. Oops, sorry.
Can I just jump in on that?
Okay, so the third.
Sorry, Jose, can I just jump in
thanks.
quickly?
Please go ahead.
The prochlorperazine is available again, and it's available in a powder, so it can be compounded as well, and it's still a good option now that it is available again more widely. That's all.
And same dose and routes and frequency as metoclopramide.
Yes.
Excellent, thank you. Okay, the third question is, what strategies do you think should be put in place locally, regionally, and provincially to reduce the risk of medication shortages and wastage? Over to Susan and Amit, because you guys put together some thoughts before the webinar.
Sure. So if you want to move to the next slide, I think one of the thing is to, you know, be really thoughtful about not wasting medication. So thinking outside the box, how can I reduce the number of medicines that I use? So the number of categories that I use, for example, and the amount that I'm prescribing. So look really carefully at the prescriptions you're writing, or if you've got order sets. Do you really need to have every single thing on that list? Do you need the quantity that we have always been used to being able to provide for our patients? So you might be better off using smaller quantities and more frequent repeats, for example, of prescriptions. So thinking about, you know, our palliative medicine kits for those places who have them. We don't have them in Newfoundland here, but when my mother died in Ontario, it was fabulous. Palliative care physician ordered the kit and everything was taken care of. But there was a lot of medicine in that some we never used. So I think those are ways of thinking about those things. Some of the other things might be, can I use one drug to combat several symptoms at the same time? So if the patient's got nausea, but they're also a bit agitated and delirium, think about Haldol rather than using two different medicines. So really put your thinking caps on and think outside the box about what we traditionally do, but what we can't do now. Amit?
Yeah, so that's excellent. I completely agree with what you're saying. Very well said. I mean, just to kind of, you know, to add some, you know, pragmatic things that have happened around that. I mean, on our sort of palliative medicine kit or symptom management kit order form, we had an option before for like morphine and hydromorphone. So we have simplified that now, and we've only gone with morphine now. You know, we had options for Haldol and methotrimeprazine. And as I mentioned earlier, methotrimeprazine has now been taken off. So before having all these multiple options and, you know, multiple vials of these medications sitting in the patient's home, I mean, from a health economics point of view, maybe it wasn't ideal from before, but definitely not. I mean, it's not going to work in a pandemic. I think that's very important because one point I want to make here is that, of course, we're talking about these COVID-19 patients who are end of life, but we're still caring for the non-COVID patients who need the symptom management kits at home. And I'm sure many of us have gotten that call in the middle of the night where somebody needed the medication to be there. So I think this strategy will ensure that the appropriate medications will be there at the right time for all the patients. I wanted to add that, you know, from my perspective, I have a special interest in working in long-term care facilities, which are, as we know, particularly impacted by COVID-19. And I think the regulations and how they order the medications are a little bit different. So I just wanted to share that we are in touch in our region with the pharmacies there. And like, for example, they, as far as I knew, they had sort of a rule that, well, once the nurse sort of gives one injection of morphine, they have to kind of discard the whole vial. And we're working with like trying to change some of those regulations in our region and having the health authority involved and so on. And I think that's just very important. Once again, it goes back to this point that we have to be very sort of strategic. And also we have to maintain really a regular stream of communication with our pharmacy colleagues in all these different jurisdictions, right? Where these patients will be, because what's sort of available today may be different in a week or two from now.
I think you brought up a good point there, and that is about the potential wastage. So in Ontario, and I think that this applies to many other provinces as well, because there's a comment from Alberta, if you prescribe a medication to a patient and that's not used, it then has to go back to the pharmacy, and it gets and it actually gets basically thrown away. So and that's by regulations. So perhaps this is an opportunity to go back to those regulations at a provincial level and say, listen, can we find another way of doing this so that we don't waste these? And if if the medication is not used on a patient, we can reapply it to for another patient.
Can I say, we had this discussion come up in the Champlain region about this, and the problem actually, even I think, begins before you get to the question of decontaminating the medications, which is that how is the medication actually getting back to the pharmacy? So, you know, people are supposed to stay in their homes. People aren't supposed to be traveling around. You know, the idea of somebody leaving like a box full of narcotics on their porch to be picked up, you know, that's, we've had people who had their kits stolen, like medications just disappearing. And so there's been a real reluctance to engage in that, not only at the level of what do I do with this potentially contaminated medication, but nobody really wanting to go and retrieve it in the first place.
How are you? Sorry, Susan, go ahead.
I was just going to say, I think, you know, changing regulations is really cumbersome stuff, because some of this stuff may be actually embedded in law or whatever, certainly around narcotics. And so looking upstream of how do I prevent multiple vials of drugs being wasted starts well before, and it starts with us as the clinicians who write the prescriptions of dispensing very small amounts and being really cautious and careful about what we're prescribing. And yeah, there is an extra burden, I think, if you provide 3 days at a time, for example, you know, that increased cost for dispensing, and I understand that can be really problematic. I think those are the places where we may be able to make some inroads in this short term, is around those kinds of things, rather than trying to change the laws.
Yeah, that's a very, very good point. James, in the Champlain region, I know when I worked there, we had changed the way in which we do the kits, the emergency kits, to, I think you identify this, I just want to emphasize that, to a just-in-time tailored kit that looks at specifically the needs of that particular patient, and for a short time, and basically a prescription that the pharmacy then basically rolled out very, very rapidly, so that it's not these generic kits.
That's right, and we still use it today. You'd be happy to know. So one of the things in Ottawa, which I don't know necessarily exists elsewhere, but we have a sort of one common sort of like 90+% of the home injectables come through one single pharmacy. It's actually a really good choke point for us in the system if you want to change practices around dispensing, to reach out to that pharmacy. And what they've done here, when initially they got this flood of symptom management kit orders, they said, okay, all of them include, you know, 10 vials, 10 vials, 10 vials. So what they did was they only dispensed 5. And that was the best of both worlds, because you give out 5, so you're giving out less medication, but there was still the other 10 on the order, so you didn't have to keep writing new orders. It was there on hand, and it was just sort of maximally efficient for everybody. And I think that's a lot of reasons why things went better that way. The other way that we might be able to save a little bit would be if people are ordering symptom management kits for facilities like retirement homes. Is it, and this is a regulatory issue, but is there a way, like if you know that there's a bunch of people in that retirement home who might need it, and instead of ordering 20 symptom management kits for a retirement home of 150 or 200 people, maybe just like a smaller number of kits that could be used for everybody would suffice. And that's maybe one opportunity to be a bit fair and flexible.
Very good. Thank you. Susan, I think you may have addressed these. Any sort of last thoughts? And Amit, on the strategies?
I think the point about being in regular communication with your pharmacist, I mean, there's very few people who are as helpful as a pharmacist to me, maybe social worker, in providing really good care. And certainly when we're working in the community, and that means multiple pharmacists that you have to talk to, but they have the finger on the pulse of what's happening today, not necessarily what's going to happen tomorrow, but today. And they can be really helpful in saying, well, this is what I got in stock and this is what I don't, and you might want to try substituting this. So they're on our side.
Very good. Thank you. Okay, so I see we're over time, and I apologize for being over time. We did bring in, there were a lot of questions and fantastic comments coming in. We're not going to have time to go through all of them. I hope we were able to bring some of them in as the webinar unfolded. We will be collating all those questions and comments, and we will be, between the panelists and the Palliative team, be putting together some responses and putting it out as a link as part of, to accompany the recording link that will be going out. So I think at this point in time, let's conclude. I think we heard from across the country variations, but also some common themes around potential drug shortages. We heard some potential options if we do encounter those drug shortages. And we also heard about some strategies, techniques that we can try and reduce the drugs and be stewards as well. And I think there's also some ideas on the longer term, some of the regulatory pieces that although we can't change right away, maybe it's an opportunity to, when the dust settles, as it were, to come back to them. I'd like to wrap up now. I'd like to thank everyone, and particularly the panelists, Susan, Ed, Patty, Amit, James. Thank you very much for being with us, for the generosity of sharing your time. Thank you for the hard work that happened before the webinar, sharing ideas and concepts. That takes a lot of time, and I know that you're all very, very busy. I'd like to thank the Palliative team, Stephanie, Brady, and John, for the support in putting on these webinars. We would appreciate your feedback. So if you get a link to evaluate, please let us know what's working, what's not working. Give us some ideas on other webinars that you think would be useful. There will be a webinar on Friday. In fact, there might be two of them actually on Friday. You'll be getting the specific time soon. I think at about noon is going to be one on health system rearrangement from a palliative care perspective. And then at about 4 or 5 o'clock in the afternoon will be one on other symptoms, managing other symptoms, and actually on palliative sedation as well. So as I said, the session has been recorded. It will be available as a link. Please do monitor the provincial websites for resources, as this is such a fluid time we're living in, where things are changing almost day by day. So monitor those. Monitor as well Palliativ's website. If there are any links there that might need to be changed, we'll try and do that. If you see anything that's outdated, please do let us know as well, so we can update those links. So at this time, I want to bid you all farewell. Thank you. Keep safe. Keep up the fantastic work everyone's doing across the country. Keep safe and look after yourselves and your families. Thank you very much. Bye-bye.
Bye, guys.
Bye. Thank you.